I wanted to talk to you this morning about what I think is a critical issue for our country and for our patients, and that is the role of publicly funded cancer clinical trials. So Marty asked me to make a few personal reflections before I begin the official lecture. And, I found this little document is folded up in a book some years ago, which was a 6th grade homework assignment that I had to write an essay about my ambition. And I wrote about how I wanted to enter the medical profession. This first line says, "Ever since I was a small boy, I've always wanted to enter the medical profession." This was in 6th grade, mind you. But then I concluded the essay by saying that I changed my mind about being a doctor, and in fact, I wanted to enter the field of medical research, searching for cures to such diseases as cancer and leukemia. Somehow those words just came together, and many years later, of course, I became the chair of the Cancer and Leukemia Group B. It was actually quite remarkable to reflect on this. So I had an early start down this path. I had the great good fortune to do my fellowship, as Marty mentioned, at the National Cancer Institute, where I got to be mentored by this motley crew. George Canellis, who's on the left, had actually already moved up to Boston by the time I arrived there, but George has been a good friend and colleague for many years. And then you see, in succession, going from left to right, Bruce Chabner, Phil Shine, Vince DeVita, and Bob Young. Phil had also already left the NCI when I arrived, but of course has been a very influential person in many of our lives throughout his career. And Vince DeVita had already been promoted to be the head of the Division of Cancer Treatment. He was still there, and we fellows still saw him and were terrorized by him periodically. But the two people who were the most influential in my own career development were Bob Young, who was my clinical branch chief, and Bruce Chabner, in whose lab I ultimately worked. And so it's particularly important to me to have learned that Bruce was the first recipient of this award. Any award that Bruce has gotten is certainly something that any of us should aspire to. And Bruce's legacy is really quite remarkable. I'm not exactly sure of the date of this somewhat discolored picture, but yeah, this was a dinner we had. So here's Bruce, Chuck Erlichman, who was in the lab at that time, who's had a very illustrious career at the Mayo Clinic, myself, Jim Doroshow, who of course is now the deputy director of NCI, was also in the lab at that time. This is Jacques Jolivet, who also trained with us and has had a career in industry and consulting, and Carmen Allegra, now the editor of the JNCI. So it was quite a group, and we learned a lot, and I still consider Bruce to be one of my closest mentors. I left the NCI in 1981. I moved on to take my first faculty position at the University of Missouri. I could give an hour-long dissertation about how life takes strange twists and turns and how, sometimes you don't make the optimal career choices. But this was the first job I took. This is a caricature of our hematology-oncology group that was sketched by a medical student at the University of Missouri back in 1982. And so our division chief was a man named Patrick Henry, also an NCI alum. And there was this group of us. There's me, looking sort of nervous about being a first-year faculty member. Although my tenure at the University of Missouri was short and didn't quite turn out the way I had anticipated, life takes some strange turns from time to time. And probably the most important thing that happened to me at the University of Missouri was meeting Mike Perry, who was a dear friend and colleague and passed away not too long ago. But one of the things that Mike did for me was to bring me to the first meeting that I ever attended of the CALGB in November of 1981, and begin to get me introduced to people in that cooperative group. And then, of course, this Mike and me at the 50th anniversary celebration, I think, of this. Actually, this might have been my retirement dinner from being the group chair, but we were together there, and You know, I worked my way up in the group, as so many of us do in our academic careers, and in 1995 was elected the group chair and joined this very iconic group with Tom Fry, who was the founding chair of CALGB, Jim Holland, who was actually the longest serving chair of CALGB. I didn't quite make it to surpass Jim, who served 18 years as the group chair, and Ross McIntyre, who was my predecessor as the chair of CALGB. It was a great 15-year tenure for me. Here we all are at the CALGB 50th anniversary, which was in 2006. And then I had the pleasure, really, of after 15 years, of handing it off to Monica Bertagnoli, shown here, as you all know Monica, in 2010, when I completed my tenure as the CALGB chair. So that was a great part of my professional career, and in many ways, probably, to me, the most enjoyable thing that I've done, and hopefully one of the most impactful. So I want to talk a little bit about why we need publicly funded clinical trials in this country, and I think they're under some duress at the moment. If you look at how new cancer therapies are developed, this is really true across all therapeutic areas, of course. Essentially, there are two kinds of sponsors. There are commercial sponsors and there are public sponsors of clinical trials. And if you contrast what the relative roles are of those two types of sponsors, well, commercial sponsors are really seeking drug registration, in some cases a device registration. The public sponsors are really seeking to optimize treatment for patients. Commercial sponsors are looking for label extension, and sometimes the public sponsors are hoping to achieve that as well by coming up with new indications for existing drugs. The commercial sponsors, essentially being businesses, are looking to expand market share. And I'd say the public sponsors are really attempting to create new knowledge. And finally, the commercial sponsors, you know, are trying to create shareholder value. They're publicly traded companies in many cases, whereas the public sponsors are trying to improve the public health. So there are places where these two types of sponsors converge, but there are then many places where they diverge, and I think we need both types of trials done by both types of sponsors in order to optimize the development of new cancer treatments. Publicly funded trials are important essentially because the publicly sponsored trials address issues that commercial trials generally will not address. Publicly funded trials compare the effectiveness of various treatment options. They directly combine or compare drugs developed by different sponsors, which of course individual sponsors are loath to have head-to-head comparisons. The publicly sponsored trials develop therapies for rare diseases. They can address the optimal dosing of different treatment regimens. They test multimodality therapies, such as radiation therapy in combination with drugs. They can identify patient and tumor subsets that are most likely to benefit from various interventions. It's the public studies that study screening and prevention strategies and focus on survivorship and quality of life. Importantly, because publicly sponsored trials are funded by taxpayer dollars, there's a strong obligation to publish even negative results, which is often not the case with commercially sponsored trials, and sometimes the negative results can be extremely impactful in medical practice. And the publicly sponsored trials often will assess cost and cost effectiveness and can provide gold standard databases for various registry studies. So let me take you through a series of examples to try to drive these points home. What about comparing efficacy of different treatment regimens? Well, this is an old SWOG study now that looked at 4 different combination chemotherapy regimens that were used for treating diffuse large B-cell lymphoma. CHOP, developed in the mid-1970s, had been the standard of care, but you know, at many other institutions had developed single institution experiences with more complicated and oftentimes more toxic regimens. MBACOD was developed at the Dana-Farber. There was Promis-Cytobomb developed at the NCI, MACOP-B. These were all in vogue. They were all reporting superior results to what had been achieved with CHOP. SWOG did the definitive prospective randomized trial that showed no difference in outcomes among these 4 treatment regimens. And then CHOP continued as the standard of care until the introduction of rituximab as the best and least toxic among the choices available to patients. And sort of this trial reset the clock in this important group of diseases. Similarly, more recently, ECOG published a randomized trial looking at 4 different platinum-based chemotherapy regimens for treating advanced non-small cell lung cancer. Each of these regimens had been touted by the institutions and the companies that were developing these as the best available treatment for non-small cell lung cancer. As you can see, this large definitive randomized trial again showed no difference in outcomes among these 4 regimens. What this trial did really was to provide choices for patients, because since there were no differences among the treatments with respect to overall survival, there are important differences in toxicity, of course, in these different regimens. And this provided an opportunity then for physicians and patients to select a therapy that might work best for an individual patient based upon the toxicity profile of the regimen. What about comparing treatments from different sponsors? Something that sponsors almost never do, of course, but that really needs to be done. So this is a CALGB trial being done collaboratively with SWOG that we designed now quite a few years ago, looking at whether adding bevacizumab or cetuximab, or as it was originally designed, the combination to chemotherapy for advanced colorectal cancer was the best strategy. But this trial really, when you think about it, is really a comparison of a Roche product to what was then a BMS product. The combination was ultimately dropped from the regimen when it turned out to be more toxic and no more effective in an interim analysis. So, you know, this is 2 antibodies, 2 sponsors. Generally speaking, the companies would have little incentive for comparing them head-to-head, but the cooperative group can certainly do that. This is another example of the same type of situation, CALGB 40502, a study in patients with metastatic breast cancer who were randomized to 3 different taxanes, Paclitaxel, generic drug, nab-paclitaxel, and ixabepilone. This study was recently reported out. It really is a comparison of a generic to 2 branded products. The branded products, of course, being considerably more expensive to the healthcare system than the generic. And the report, somewhat surprisingly, I think, was that the generic drug did best. So this was presented at ASCO just this last year, at least on the progression-free survival endpoint. And you can see Paclitaxel was clearly the superior therapy. The 2 branded, more expensive products did not do as well. Again, you know, it's only a publicly funded system that would do a trial like this to clearly nail down which was the best treatment option for patients with advanced breast cancer. ECOG has done a similar type of a study in the adjuvant setting for patients with renal cell carcinoma, comparing sunitinib to sorafenib to placebo. Again, it really boils down to a comparison head-to-head of a Pfizer drug to a Bayer drug to a placebo. The results of this one are not out yet. What about developing therapies for rare diseases? The cooperative groups have been very well suited to do this. A great example, I think, from the CALGB experience was the development of 5-azacitidine for treatment of myelodysplastic syndrome. This really was the work of Lou Silverman and Jim Holland at Mount Sinai Medical Center, who believed in this drug, did all the initial early phase clinical trials of this drug, brought the drug into the CALGB for 2 phase 2 studies, and then ultimately a definitive randomized clinical trial of 5-azacitidine versus best supportive care in patients with myelodysplastic syndrome. That was clearly a positive trial. This just shows the event-free survival in favor of 5-azacitidine. There was also a significant quality of life advantage in favor of 5-azacitidine that was demonstrated in a companion quality of life study. This is the study that a commercial sponsor then brought to FDA and resulted in the FDA approval of 5-azacitidine as the first FDA-approved drug for treating myelodysplastic syndrome. Optimizing dosing, you know, strange as it may seem, we don't always know the best way to give chemotherapy when drugs first come out into the marketplace, and there are important refinements that can be made even once drugs are commercially available. So I would offer this as a great example. The GOG and I think SWOG also did prospective randomized trials looking at intraperitoneal versus intravenous cisplatin with IV paclitaxel in patients with advanced ovarian cancer. And as you all know, a series of these randomized trials clearly demonstrated the superiority of intraperitoneal route of administration. There's no commercial sponsor that's going to look at this, even though these trials you know, have demonstrated that giving cisplatin intraperitoneally clearly improves the outcome of women with ovarian cancer. Never mind the fact that there hasn't been great uptake of this in clinical practice, and that can be a whole other discussion. But I think the notion here that, that a study like this would not be done by a commercial firm is important to keep in mind. Similarly, we did a study, one of many done in CALGB, is adjuvant therapy for early stage breast cancer, where we were looking at comparing the sequencing and the frequency of dosing of various chemotherapy drugs. This was the 9741 study, looking at giving the therapy every 3 weeks versus every 2 weeks, and then giving it each drug following on the other, or giving 2 drugs followed by the third in a randomized factorial design, showing, again, very clearly that the dose density was important in improving the disease-free survival and the overall survival of women with stage 2 breast cancer, and again, leading to essentially a new standard of care for at least some women with early stage breast cancer. There's probably no better example of the importance of publicly funded clinical trials than the experience in treating pediatric acute leukemia. This is just a summary that actually Michael Link showed in his ASCO presidential address this last summer of the outcome of children's oncology group studies in children with ALL over many decades, going back to the 1960s. And you can see very clearly in the early years, only about 5% of kids with ALL survived, and through a series of publicly funded clinical trials with really the introduction of no new drugs, but just optimizing the utility of the available chemotherapy drugs, the progressive improvement in outcomes such that, you know, now 90+% of kids with ALL are long-term survivors. Combining treatment modalities, again, the kind of thing that you know, commercial firms are unlikely to do, but that can be highly impactful. So I just picked a couple of recent examples. This was the intergroup gastric adjuvant trial that clearly showed that following surgery with chemotherapy plus radiation improved the outcomes of patients with gastric cancer. And these are the updated data that were just published earlier this year. This is a combined modality study done by RTOG demonstrating that giving radiation therapy with concurrent cisplatin was clearly superior to radiation therapy alone. This is the concurrent. This is sequential. This is radiotherapy alone in larynx preservation in patients with laryngeal cancer. So again, you know, from the patient's perspective, there's almost nothing that could be more important than preserving their speech. This has become a standard of care therapy now instead of total laryngectomy for patients with at least early stage and localized laryngeal cancer. Identifying patient subsets. So we're all interested in individualized medicine, personalized medicine, precision medicine, Dr. Varmus's favorite current terminology. You know, the concept being that we want to get the right patient to the right treatment to the right patient at the right time. And how are we going to learn about how different subsets of patients respond to different therapies? Well, again, the cooperative group studies, the publicly funded studies, are uniquely suited to do this. This is a summary slide that Clara Bloomfield published a number of years ago now, looking at all of the molecular subtypes of AML that had been defined up until that time, largely through the work of the cooperative groups. Almost all of this data was generated from using leukemia samples that had been collected by the CALGB and other groups in fresh frozen tissue banks over many years, all from patients on clinical trials who had known treatments and known outcomes, and demonstrating all of these different molecular cytogenetic subtypes of acute leukemia, many of which have prognostic importance, and some of which now actually have targeted therapies. And I'll return to that point in another example a little bit later. Another kind of an approach, so these are the results from the CALGB 9344 study. Again, the study that led to the introduction and now common use of Paclitaxel as part of adjuvant chemotherapy for patients with early-stage breast cancer. The study was a randomized trial looking at Adriamycin cyclophosphamide with or without Taxol, and again clearly showed an improvement for patients who were receiving the Paclitaxel as part of their adjuvant chemotherapy. But the question that we were interested in then, and I think we're still interested in now, is this is obviously a small incremental improvement. And so who are the women who really need this additional therapy, and who are the women who really benefit from it? And is there a way that we can identify those patient subsets? Dan Hayes, when he was with CALGB, did some very simple biomarker studies, but actually that turned out to be quite informative, just looking at outcomes in this patient population based upon ER status and HER2 status, and clearly showing that essentially all of the benefit for giving adjuvant Paclitaxel was in the group of women who had HER2 negative and ER negative tumors, that's the group here, or HER2 positive ER negative tumors, the group here, who really derived most of the benefit. And the women who had HER2 negative ER positive tumors, which was actually the largest subset of women in this more than 3,000 patient study, derived no benefit from receiving adjuvant Paclitaxel as part of their chemotherapy. So they were just getting lots of toxicity and no clear benefit from the treatment. So we clearly need, this is, by today's standards, a fairly primitive biomarker study, but we clearly need to be able to use these large clinical trials where we have bank tissues to ask these types of questions, to be able to understand who really needs the therapies that we are studying and then ultimately prescribing. Another interesting analysis just reported about a month ago from another CALGB adjuvant breast trial, the 40101 study. So this was a study in early stage breast cancer that was comparing taxane chemotherapy to standard cyclophosphamide-based chemotherapy in women with early stage breast cancer, looking at germline polymorphisms in genes that might predict who gets peripheral neuropathy from the taxane. So obviously this is a very common and significant complication for many women who were receiving Taxol, and two genes were identified, and several SNPs were identified in those genes that were related to the risk of developing Paclitaxel-induced peripheral neuropathy. And you can see that this is probability of developing neuropathy versus cumulative dose for the EPHA5 gene and FGD4 gene and the genotypes that were involved. And this type of analysis could be done because in this large clinical trial, we had collected germline DNA from all the women who were participating in the study. We knew the phenotype, we knew the outcomes, and these data still have to be further validated, but this may give us a clue going forward as to whether we can genotype a woman if we're considering using Paclitaxel as part of adjuvant therapy, and then try to at least anticipate what the risk of peripheral neuropathy might be, and even use that information to consider whether or not Taxol is an appropriate part of the treatment regimen, perhaps based upon other biological characteristics of the patient's tumor. So if you put together information from the tumor, information from the germline, you can really begin to customize the therapeutic approach. Prevention studies, again, essentially prevention studies can only be done in a publicly funded system because it takes too long to get to an outcome, and there's no drug company that's going to want to wait many, many years and study many thousands of patients to try to get to those outcomes. So this is the initial report in 2006 of the STAR trial for breast cancer prevention. This is a study comparing tamoxifen and raloxifene. And in the initial report, both drugs looked to be effective in preventing invasive breast cancer. Tamoxifen had already been shown to be beneficial for that purpose. And tamoxifen looked to be a little bit better in preventing as well non-invasive breast cancer. There was a different adverse event profile, of course, with more uterine cancer and many more thrombotic events in women receiving tamoxifen. Now, these data, as you know, were then updated in 2010, and interestingly enough, in the update, tamoxifen turned out to be superior to raloxifene in reducing the risk of invasive breast cancer. But on the toxicity side of the equation, tamoxifen clearly increased the risk of invasive uterine cancer and of thrombotic events in patients. So, now there's a real risk-benefit analysis that has to be done in recommending these therapies to a woman who has a high risk of invasive breast cancer and a low risk of cardiovascular events might preferentially be recommended to get tamoxifen. A woman who has a lower risk of breast cancer but some significant cardiovascular morbidities might be recommended to get raloxifene. And this is the kind of information that I think doctors and patients need to have to be able to make these risk-benefit analyses. Publishing negative results. I see Tom Shea here. Tom will certainly remember CALGB 9082. This is one of the few prospective randomized trials that was undertaken at a time when women were beating down the doors of their doctor's offices and their insurance companies to try to get high-dose chemotherapy for treating breast cancer, because many institutions, particularly one down the road from here a little bit, had been reporting the value of using high-dose chemotherapy in treating breast cancer. We undertook this study in CALGB, comparing a high-dose regimen to sort of an intermediate dose regimen of the same drugs in women with high-risk breast cancer at 10 or more positive nodes. And again, the outcomes showed no difference in event-free survival in favor of the high-dose chemotherapy. The data were published after lots of psychotherapy done with Bill Peters, but the data ultimately were published in the JCO, and of course there were a number of other prospective randomized trials that had been reported around the same time, all of which failed to show a benefit for this approach, and this approach essentially then faded from clinical use at that time. What about assessing cost effectiveness? Another important issue that we're all facing at a time of skyrocketing healthcare costs. Another issue that the drug companies, of course, are typically reluctant to address very overtly because there's oftentimes a great sort of imbalance between the cost and the effectiveness of some of the newer drugs. So I'll just give you this example. This is the BR21 study that was done by the NCI Canada Clinical Trials Group. This was the registration trial that led to the FDA approval of Erlotinib for treating advanced non-small cell lung cancer. It's very straightforward, Erlotinib versus placebo in patients with advanced disease. A clear benefit shown in favor of using Erlotinib, albeit a modest improvement. The NCI Canada did a cost-effectiveness analysis, so the clinical trial showed a median overall survival benefit of 2 months. The incremental cost-effectiveness ratio was $95,000 Canadian for a year of life saved. Interestingly, when they began to look at subsets of patients who might be the ones most likely to benefit from the Erlotinib therapy. And this analysis was done before there was much data out on EGFR mutations. So they looked at EGFR amplified subset by FISH, but looking there the incremental cost effectiveness ratio was reduced by a third, down to $33,000. And if they looked at the never smoker subset, so a group of patients likely to be enriched for EGFR mutations, again, the cost effectiveness ratio was substantially reduced. So I think the point here being that, number one, you can do these sorts of analyses if you collect the right data, and number two, if you, of course, give the drug to the patients who are most likely to benefit, you're going to get the best cost effectiveness. Similar type of analysis also done by NCI Canada for cetuximab in patients with colorectal cancer. So over here you see the overall results. Again, this was a registration-directed study done by NCI Canada, cetuximab versus best supportive care versus patients receiving best supportive care alone. In the overall study population, the cost-effectiveness analysis was about $200,000 per life year gained for using cetuximab. But if you did the same analysis in the patients with K-ras wild-type tumors, eliminating the patients with K-ras mutated tumors who were not likely to benefit, still expensive, but you could bring down the cost effectiveness to about $120,000 per life year gained. And so, you know, again, I think it's the publicly funded systems that have the incentive to do these sorts of analyses far more so than the drug companies do. And then what about providing gold standard databases? I put this in here because I think it's increasingly clear that we're not going to be able to continue to rely on large prospective randomized clinical trials to learn everything that needs to be learned about cancer and cancer treatment going forward. There are not enough resources, there are not enough patients, particularly as we do more and more molecular subsetting of patients, to actually be able to mount large prospective randomized trials to answer every question. So we're going to have alternative ways of learning. One of the ways of learning, of course, is to do either retrospective analyses of data sets or prospective observational registries, which, although they're prospective because they're not randomized, you know, can be done far less expensively than randomized intervention trials. If you're going to do an analysis of an existing data set, you'd like to have a sense as to how well does that data set reflect the actual results that one might get from a clinical trial. So here's the practical problem. And certainly, you know, Hai is an expert in this. Most people who are diagnosed with cancer, of course, are elderly. Most people who are on clinical trials of anti-cancer therapy are not elderly. And so how are we supposed to learn about what are the effects of new cancer treatments in the older patient population? And the risks and benefits of many anti-cancer therapies are actually unclear in older patients. One way of doing this is to link data sets, and what's often done is linking the Medicare data set to the SEER epidemiologic data set on cancer incidence. But you'd like to have a sense that what's in the Medicare data set actually is reflective of the actual outcomes of patients who might be treated prospectively. So in this study, Elizabeth Lamont, and working in CALGB, linked the CALGB data set on a breast cancer study to the Medicare data for the same patients in that study based upon their Medicare claims data. And essentially what she found was that the Medicare data set very accurately reflected the disease-free survival of patients as determined in the clinical trial. Interestingly, what the Medicare data set did not reflect very well was the toxicity data. I'm not showing that slide, but I think that this gives a high degree of confidence that what we find in the Medicare data set, at least for cancer outcomes, is likely to be reasonably well reflective of what the actual outcomes of patients might be. So that's important. I want to make a few comments about comparative effectiveness research. As you know, this has been a buzzword now in Washington for the last several years. The Institute of Medicine issued a report on comparative effectiveness research, which they defined as the generation and synthesis of evidence that compares the benefits and harms of alternative methods to prevent, diagnose, treat, and monitor a clinical condition or to improve the delivery of care. The purpose of CER, as stated by the IOM, is to assist consumers, clinicians, purchasers, and policymakers to make informed decisions that will improve health care at both the individual and population levels. So, what's the relationship between clinical trials and comparative effectiveness research? And I would say that, in my own view, clinical trials really are the bedrock of comparative effectiveness research. Clinical trials demonstrate what can work. Comparative effectiveness studies demonstrate what does work when those therapies are applied in a real-world population. And I think I'll just skip ahead here. Let me give you this example. I saw Ben Calvo here earlier, so I know there's at least one surgeon in the room. So I'll give you this example of the case of laparoscopic colectomy. So this is a very important pivotal trial done by the cancer cooperative groups, led by Heidi Nelson and the North Central Cancer Treatment Group, the COST trial. This is a study comparing laparoscopic colectomy to open colectomy in patients with early stage colon cancer. And I won't go through it in detail, but these are the overall results, essentially showing no difference. This was a well-designed, non-inferiority trial designed to demonstrate that laparoscopic colectomy was no worse than open colectomy, and in fact, it achieved that goal. That was the data on recurrence. This is the data on survival. So I think this trial made it very clear that laparoscopic colectomy could be a good option for patients with early stage colon cancer. There was a similar trial that was done in the UK, known as the classic trial, essentially showing the same results, comparing open to laparoscopic colectomy, and again showing no difference in survival in either patients with colon cancer. And in the rectal cancer patients, at least in this study, the laparoscopic colectomy patients actually looked like they did a little bit better. So the conclusion, sort of in the comparative effectiveness world, is that, well, laparoscopic colectomy can work, in the context of a clinical trial setting. The real question is, does it work if it's applied in the real-world population? So how do you address this? Well, first you'd like to know something about the uptake of this strategy. So this was a study published a few years ago by a surgeon in Canada who did a survey of more than 1,200 members of the Royal College of Physicians and Surgeons of Canada. 462 of them actually admitted to doing colorectal surgery, and 54% of those said that they did laparoscopic colorectal surgery. And if you looked at who were the ones who were doing the laparoscopic surgery, well, it was people who had been in practice for a shorter period of time. So the younger surgeons, they tended to be male, they tended to practice in Quebec, and maybe that's because that's where they were trained. They tended to have university hospital affiliation, and they tended to have done a minimally invasive surgery fellowship. So they had specialized training to do this technique, and so, of course, they were the ones who were doing it. Now, interestingly, this is an analysis that was published by the American College of Surgeons looking at the National Cancer Database on laparoscopic-assisted colectomy. So this is real-world data. This is not clinical trial data. And, again, it shows, like the COST and classic trials, that if you look at 5-year survival for laparoscopic-assisted colectomy or open colectomy, that laparoscopic-assisted colectomy certainly compares very favorably. And these were the Kaplan-Meier plots, again, for stages 1 through 3, the overall study population. The laparoscopic-assisted colectomy patients certainly did at least as well, if not better, than patients being treated with open colectomy. Again, this is not a randomized study. This is just, 2 sets of outcomes data from a large observational data set. Now, in this study, they actually then looked at what were the outcomes for the patients in the database versus the outcomes for the patients in the COST trial, and you can see that they weren't quite as good. So 3-year overall survival was 75% for the patients in the database versus 86% for the patients in the cost trial, and 5-year survival 64 and 76%. And this is, in a sense, what you might expect. That is, when any new therapy is applied in the real-world population, it tends not to perform quite as well as it does in the clinical trial population for a whole variety of reasons. But the summary from this analysis, in my view, in a sense, is the clinical trials show laparoscopic colectomy can work. The observational studies, the database studies, show that laparoscopic colectomy, in fact, does work in the community, but not as well as it can, because the outcomes are not quite as good as they are in the clinical trial setting. And I think there are a variety of reasons for that, including, of course, patient selection, as well as the expertise of the physicians who are actually doing the procedure. Another interesting and I think informative example regarding comparative effectiveness research, and again, many of you will be well familiar with this CALGB study, 9343, that looked at the impact of breast radiation therapy in older women receiving tamoxifen. So these were women 70 years of age and older with early-stage breast cancer, ER positive, all of whom got tamoxifen. Some of them also had breast radiation. The study, when it was first published and subsequently updated, showed no difference in survival in favor of the use of radiation. There was a small difference with respect to local recurrence, but didn't translate into any adverse impact on survival. And in fact, most of the deaths of the women enrolled in this trial were non-breast cancer-related deaths. I mean, they were dying from other comorbidities that were prevalent in an older patient population. Now, one might have thought that when these clinical trial data came out, that they would have some impact on the use of radiation therapy in older women with breast cancer. And in fact, just a short time ago, we saw this publication in the JCO looking at a SEER-Medicare analysis of the use of radiation therapy in older women following on the publication of the clinical trial data. So this is when 9343 was first published. This is when 9343 was updated just a year or so ago. And this is the 70 to 74-year-old group, the 75 to 79-year-old group. It was these two groups that were the predominant patient population included in the CALGB study. And you can see essentially no downturn in the use of radiation therapy, even in the wake of very definitive clinical trial results. So this, I think, is very important information for physicians, for policymakers. We really need to understand why is it that there's essentially no uptake of the clinical trial results and influencing community practice, because it's a toxicity issue, it's a cost issue, it's a convenience issue for these older women with breast cancer. But that's what comparative effectiveness research is really all about. It can't be done, though, without having the bedrock of the clinical trial data to inform the observations that are made in the real-world setting. Finally, since this is the Society of Translational Oncology meeting, I wanted to talk a little bit about the impact of the cooperative groups in doing translational research, which I think is very significant. So this is just a schematic of the translational science infrastructure that we built in CALGB over many years to show you all of the components that are required to do this in a multi-center setting. I won't dwell on it, but basically, we had a committee that was sort of overseeing everything. We had committees that were developing the science, like the Leukemia Correlative Science Committee, or the correlative science activities embedded in the disease committees. We had a number of tissue banks, a leukemia tissue bank, a lung cancer tissue bank, our pathology coordinating office, which is where all the paraffin blocks went. We had a number of reference laboratories, one here at UNC, actually, that Chuck Peru was involved in helping us to develop, one at Duke. And it takes all of this in a multi-center setting to be able to do the translational research that we think is so valuable. What kinds of biomarker studies can be done in the cooperative groups? I'll give you some examples. So This is a great example of how you can turn a negative into a positive. This was a adjuvant colon cancer study done in CALGB a number of years ago, 89803, trying to determine whether or not adding irinotecan to 5-FU-leucovorin would produce additional benefit in patients with node-positive colon cancer. It was a negative study. There was no impact of adding irinotecan, but this was a 1,260 patient randomized clinical trial, and we collected tissue blocks on all the patients in the study, and they then became an extremely informative source of information for learning more about colon cancer. So as an example, Monica Bertignoli actually reported these data looking at the impact of mismatch repair deficiency on outcomes and suggesting that patients with mismatch repair deficient tumors might actually benefit from irinotecan-containing chemotherapy. That's shown probably best over here, but you can also see it on the survival curve. But essentially, these were the patients with MSI high tumors who received irinotecan. In black are the patients with, in yellow are the patients with MSI high tumors who did not receive irinotecan. So clearly, the irinotecan seems to be making some difference in that particular subset of patients, about 15% of the colon cancer population. In the remaining patients, the patients with MS stable tumors, there was no differentiating effect of adding the irinotecan. So this is still a hypothesis generating analysis, but I think one that is quite provocative. We also learned by using the tissue blocks in 89803 that K-ras mutation in the primary tumor is not prognostic in stage 3 colon cancer. We also learned that BRAF mutation is prognostic in stage 3 colon cancer. And again, here you can see, looking at overall survival, BRAF wild-type tumors, BRAF mutated tumors. There may also be a treatment biomarker interaction in this subset as well. So if one, again, looks here at the BRAF mutated tumors receiving IFL, that's this yellowish line here, and compare that to the BRAF wild-type tumors. Let's see if I got that right. No, sorry. If you look at the BRAF mutated tumors, that's here receiving IFL compared to the BRAF mutated tumors receiving FU-leucovorin. That's these two curves. Clearly, there seems to be an advantage to the use of irinotecan in the BRAF mutated patient population. So again, hypothesis generating, but an observation that could only have been made in this setting. We did a randomized phase 2 study in patients with advanced non-small cell lung cancer, trying to see whether or not adding a COX-2 inhibitor or a 5-lipoxygenase inhibitor or both to chemotherapy would produce any advantage. Again, this turned out to be a negative trial with respect to selecting a winner regarding a therapeutic strategy. But one of the interesting observations made in this study, again by collecting the tissue blocks, was that non-small cell lung cancers that had high expression of COX-2 had an adverse outcome. And that's shown in the top here. These are the high COX-2, these are the low COX-2 expressing tumors having a more favorable outcome than the high COX-2 expressing tumors. And when those tumors that had high COX-2 expression actually received a celecoxib, a COX-2 inhibitor, they had a better outcome. So again, a very provocative hypothesis generating study that then led to this prospective randomized clinical trial that is currently ongoing, formally testing the utility of adding celecoxib to chemotherapy in tumors that are high COX-2 expressing tumors. What about drug and biomarker co-development? Well, I showed you earlier all the data on the various molecular subtypes of AML that have been derived from studying the CALGB leukemia tissue bank specimens. One of those is the FLT3 internal tandem duplication population in patients with AML who clearly have a worse outcome than other patients with AML. That led to this large prospective clinical trial now completed, in which patients were screened for FLT3 ITD or FLT3 mutation. They were then randomized to chemotherapy with placebo or chemotherapy with a PKC inhibitor, PKC412, which is a FLT3 inhibitor. And this was a study that we did collaboratively with Novartis, run on in 8 countries on 3 different continents, with harmonized molecular testing in multiple different laboratories across the globe, and the study's now been completed. Finally, the cooperative groups, of course, can also do marker validation studies. So this is the TAILOR-X study that I'm sure most of you are familiar with, seeking to validate the utility of the Oncotype DX test in selecting patients with various risk levels with breast cancer. So in this study, as you know, women with ER/PR-positive tumors have the Oncotype DX test done. If they have a high recurrence score, they're assigned to chemotherapy plus endocrine therapy. If they have a low recurrence score, they're assigned to endocrine therapy alone. But if they have an intermediate recurrence score, they are randomized in a non-inferiority design to endocrine therapy plus endocrine therapy plus chemotherapy. The goal of the study to try to demonstrate that these women can safely forego chemotherapy. So the goal is to show that endocrine therapy is not inferior to the combination of endocrine therapy plus chemotherapy in women with an intermediate risk of recurrence. This study, too, has completed accrual, and the results are pending. We also used another CALGB data set to validate the Oncotype DX colon cancer test that is now commercially available. This was from another large clinical trial done in patients with stage 2 colon cancer. Again, about 1,800 patients in this trial. The trial itself, which was comparing a monoclonal antibody, edrocolimab, to placebo as adjuvant therapy in stage 2 disease, failed to show a benefit from the monoclonal antibody. So the study essentially became a large prospective natural history study, probably the largest ever done in patients with stage 2 colon cancer. We had the tissue blocks, and we were able to validate the utility of the Oncotype DX colon test as a test that could show a strong relationship between the recurrence score and the actual risk of recurrence. So just to summarize, I hope I've made it clear that I think the cooperative groups have the capacity to conduct many types of biomarker studies, including formal validation studies, and that publicly funded clinical trials are really essential to directly compare drug treatments, to develop combined modality therapies, to study chemoprevention and rare diseases, to identify various patient subsets, and to study health outcomes, cost, and cost effectiveness. Where is the cooperative group program going? I'll just conclude with a few editorial comments about that. So this is the cooperative group program as we have known it for about the last 60 years, with about, there are, I think, 9 adult groups and COG as the children's group. So we've had all these cooperative groups. They've all had their own organizational structures. In more recent years, there are disease steering committees that have been working with the groups to develop clinical trials. And then the accrual has been through in a variety of venues, including academic medical centers, CCOPs, and the community at large. Now, as you know, the Institute of Medicine issued a report on the cooperative group program. I happen to have served on that committee. That report made a number of recommendations regarding the reorganization of the cooperative groups. The one thing that the report did not actually recommend was the consolidation of the cooperative groups. What the report recommended was the consolidation of some of the functions of the cooperative groups to reduce redundancy and improve efficiency. The NCI read it a little bit differently, however, and concluded that the IOM committee was recommending consolidation of the cooperative groups, and have urged the groups to move in that direction, which of course they have. And what the NCI now wants to move forward with is what is now being referred to as the National Clinical Trials Network, which basically will be 4 adult cooperative groups and the COG interacting in some way, illustrated. This is an NCI slide, not mine. So it illustrates their very clear thinking on this matter. interacting together in some way, and then with all of the venues in which the accrual will take place to create this national clinical trials network. So the result, of course, has been that the CALGB essentially no longer exists. So those of us who spent many, many years working in that group are now working in the Alliance for Clinical Trials in Oncology, which is the result of the merger of NCCTG, ECOG, and CALGB. The Children's Oncology Group continues. SWOG has decided to remain independent. Akron and ECOG have merged to form a new cooperative group. And then, of course, NSABP, RTOG, and GOG have formed what seems to me to be some sort of a holding company with some sort of an umbrella organization that's governing what looked to me to be still 3 independently functioning cooperative groups that claim to be a unified structure. But, you know, time will tell there. The goals of the National Clinical Trials Network, as articulated by the NCI, are to provide an essential infrastructure for publicly funded trials in treatment, control, screening, diagnosis, and prevention, that the NCTN will provide a unified clinical and translational infrastructure for the extramural cancer community, including investigators, patients, advocates, and industry, that the NCTN efficiently function to answer critical questions that are not well supported in a commercial environment, and try to illustrate to you what those types of questions might be. But it's clear that the NCTN will eventually replace the program we have known as the cooperative groups. In fact, as many of you probably know, all of the cooperative groups are now undergoing a head-to-head recompetition. They're all recompeting their grants at the same time. But if you look at the RFA that's been distributed by NCI, it is not calling for application to be a cooperative group. The RFA is calling for application to perform a function that can be supportive of the National Clinical Trials Network. So you can apply to be an operations center, you can apply to be a statistical center, you can apply to be a translational research unit, you can apply to be a quality imaging quality control center, and eventually they'll be having applications out to be a tissue bank as well. Each of these applications, will have an individual PI, in some cases multiple PIs, but in most cases the PI will be a different person for each unit, each functional unit. So whereas when I was the CLGB chair, I was the PI on essentially all the CLGB grants and therefore had control of all the CLGB resources. Going forward, the group chairs will actually have very little control of the group resources because they will be distributed across a group of PIs who have responsibility for these various functional units. So I think there are considerable risks in replacing the cooperative group program, but the cooperative group program, as we've known it, in my estimation, is now ancient history, will be replaced by the National Clinical Trials Network, and it remains to be seen how effective that will be. But the risks are loss of institutional allegiance and cost sharing. There's no institution that participates in the cooperative groups that doesn't lose money doing so, but most institutions have been dedicated members of cooperative groups for decades because they find various other sorts of value in making those contributions. There will be, I think, no doubt, fewer publicly funded clinical trials. The budget that NCI has set aside for the National Clinical Trials Network is about $160 million. That is the same budget that the cooperative groups had in fiscal year 2000. So in fiscal year 2014, when the NCTN is funded, it will have the same absolute dollars, but the purchasing power of those dollars will be substantially below what the group funding has been up until now. So inevitably, there'll be fewer trials and lower accrual. I think a huge potential loss is the loss of young investigator mentoring. Many of us grew up in the cooperative groups, learned a huge amount in the cooperative groups about how to design high-quality clinical trials. There'll be many fewer opportunities for young people to do that. I think that with a large network instead of individual groups, there will inevitably be loss of competition to drive innovation. The NCTN, I think, will become a research infrastructure, but not a research engine, as many of us have felt the cooperative groups have been for many, many years. And time will tell whether the NCTN is able to set new standards of care for cancer patients. So I think finally I'll just leave you with the thought that the future of cancer care, I think, depends on a robust, publicly funded clinical trial system. I hope the NCTN will provide that to us going forward. It will clearly be a different way of doing business from what we've been accustomed to in the cooperative groups. But, if we have a system that produces high-quality clinical trials that are started up quickly, accrued quickly, and get answers quickly, we'll still have an important system, and we'll have to be very focused in the questions that system attempts to ask and answer. So thank you very much for your attention and for the great honor of the Pinedo Prize.
Great talk, Rich. I think Rich is heading back for his high school reunion at Stuyvesant High School in New York. So we have to get him out, but I think we could take a question. Two. Yes.
Just a comment that since all of this is being taped, please speak into a microphone and give your name and affiliation.
Manuel DiLiberto, Campbell University. In terms of the FDA and now its pressure to do more patient identification in clinical trials and the need for concurrent diagnostics in that, I think that will provide more impetus for getting the data that we really need.
Well, there's no doubt about that. It'll also provide many more challenges in terms of, having the right biomarker to identify the patient population we want to study, screening patients, to identify the population to be studied and so on. But again, I think, all of the common cancers are being essentially broken down into groups of rare tumors. And to the extent that the cooperative groups and publicly funded systems are well positioned to study rare tumors, I think that's going to be a continuing important role for them.
Tom?
Thanks, Tom Shea, UNC. Thanks, Rich. That was great, even with your comment about 9082, but, that happens. But more importantly, clearly your summary there is a little bit sobering, as I think we all are a little bit concerned about how things are going to move forward, particularly regarding younger investigators and so on. But I guess my question for you, from where you sit, realizing that to some degree the ship has sailed, we'll have to see sort of where it docks. But what's happening from ASCO and the other leadership groups in regards to this kind of reorientation of what we're doing?
Well, I think, I think ASCO has come out in their blueprint document on the future of clinical research, stating very clearly that they support the need for a robust publicly funded clinical trial system. I don't think that ASCO is necessarily advocating for the cooperative groups as we've known them. And in fact, as you say, that's a position that's really no longer tenable. The ship has sailed. The groups are going to essentially, fade away, I predict. I may be wrong, but, I think there will continue to be legacy studies, of course, for some years to come. But my guess is that by 5 or 10 years from now, when the groups, when this NCTN is going to be recompeted one more time, that it's really going to, what's going to be recompeted is an infrastructure. There's going to be op centers and stat centers and tissue banks and the CTSU for accrual and the steering committees to design studies. And then, what do you need cooperative groups for? So I think the real issue that we all have to stand up for is the need for public support for cancer clinical trials, because for all the reasons that I tried to articulate, I think we desperately need that. We cannot allow all the new cancer treatment development in this country to be done by the pharmaceutical companies, because we will learn far less than what we really need to know. So I think that's the position we have to take.
Very good. Rich, thanks again. Sure. Terrific talk, and congratulations on the Pinedo Prize. Thank you.